Welcome to our first grand rounds of the Department of Psychiatry of this academic year. We're very pleased to have two wonderful speakers for us today, and let me introduce them to you. Miles McFall, Ph.D., is Chief Psychology Service and Director of Outpatient Mental Health Services at the Seattle VA. He has a Ph.D. in Clinical Psychology. He's currently professor in the Department of Psychiatry and Behavioral Sciences at our university. He formerly directed inpatient and outpatient PTSD programs at VA Puget Sound healthcare systems for nearly 25 years. Dr. McFall has conducted a number of clinical treatment trials for veterans with PTSD and published widely on the topic of tobacco cessation in veterans with PTSD. He provides leadership within the Department of Veterans Affairs and Education and dissemination of evidence-based clinical practices for tobacco cessation in veterans with PTSD and other mental disorders. And our co-speaker is Dr. Andrew Saxon, who is professor in the Department of Psychiatry and Behavioral Sciences with us. He is director of the Addictions Treatment Center at VA Puget Sound Healthcare Systems, and he's director of the Addiction Psychiatry Residency Program here at the university. He completed an internal medicine internship and worked for 4 years as an emergency room physician. Subsequent to his general psychiatry residency at the University of Washington, Dr. Saxon has 25 years of experience in clinical and research addiction psychiatry. Dr. Saxon is board certified with additional qualifications in addiction psychiatry. He sits on the editorial boards of journals such as Drug and Alcohol Dependence and General Hospital Psychiatry. Dr. Saxon's current research work is supported by NIDA, National Institutes of Alcohol Abuse and Alcoholism, and the VA, and involves pharmacotherapies and psychotherapies for alcohol, cocaine, nicotine, and opioid dependence, as well as work in co-occurrence of substance dependence and PTSD. Now, our illustrious speaker.
A smoke right after the battle for Fallujah in Iraq. This is a soldier whose own struggle against PTSD was later featured in the Wall Street Journal. And here you'll see that about half of these soldiers in Iraq, while socializing, are having a smoke in the war zone. And here you'll see a soldier, while being medevaced, is being comforted by a cigarette. So a little more detail about PTSD. As you can see from this slide, rates of smoking in our VA patients with PTSD are comparable to those found in survey studies of community samples of Americans with PTSD. So if you do survey studies, epidemiological studies, you'll find that of those people who have a screening diagnosis of PTSD, at least, using telephone-based interviews, about 45% of them smoke. So that's somewhat similar to what we see in our own patient population. Veterans with PTSD tend to smoke more heavily, which of course further increases their liability for tobacco-related diseases, lung cancer in particular. And individuals with PTSD have a much harder time quitting smoking when they try to do so compared to those without mental illness. Tobacco cessation may very well contribute to the considerably much higher rates of medical morbidities, healthcare utilization costs, and premature mortality now found to be true for veterans with PTSD. Healthcare costs for our veterans with PTSD are much higher, 2, 3, 4-fold higher than for veterans without PTSD. Well, let's talk a little bit about what we're trying to do about it. In the VA, probably similar to other healthcare systems, there's a platform for delivering tobacco cessation treatments. The gold standard in the VA in the past has been to refer patients to specialized smoking cessation clinics. These are very good clinics that are run by nurses, psychologists, sometimes internists, people who do tobacco cessation. A large percentage of their daily work is what they're doing. So they're really very good at it. The trouble with that is that only about half of people referred to these specialized tobacco cessation clinics, at least in the VA, have typically show up. And we did some studies at our facility, pilot work, showing that of those PTSD patients who did show up upon referral, only about half of them ever went back after one session, which is a bad sign, because if you don't get the treatment, you're unlikely to get the cure. Now, primary care providers are increasingly picking up the challenge of providing tobacco cessation interventions, but they have limitations as well. Primary care just can't see patients frequently or long enough to deliver intensive tobacco cessation interventions, particularly those needed by chronic, intractable smokers, those with mental illness, for example, who are a particularly vulnerable population. A third approach is actually referring smokers to telephone quit lines for counseling. That's being piloted and has been advocated, but really is not widely used. It's still a process under development, at least in the VA. Now, this has all led us to the situation where our former Surgeon General, Dr. Satcher, about a decade ago, declared that our lack of progress in tobacco control is more the result of a failure to implement proven strategies than the lack of knowledge about what to do. That's actually a powerful statement, because there are evidence-based treatments for tobacco dependence that are well known and give reasonable efficacy, depending on the study you read, 20%, 25%, at least over the short term. And the problem really is in delivery. Healthcare organizations have found it to be quite challenging historically to provide this tobacco cessation treatment to their enrolled patients who smoke, despite the fact that some 50 to 70% of smokers say they wish they could quit. We're getting better at it as a healthcare organization, not only VA, but in the community. But even as recently as the early 2000s, only about 20% of patients in the VA who are tobacco users who desired to quit and who desired treatment were actually getting those desired services. So something was going wrong where some 80% of smokers who wanted to quit were actually getting, they weren't getting what they wanted. And to put this in perspective, the situation actually is even worse at non-VA healthcare organizations, where those numbers are even lower than what I cited for the VHA historically. I think things have improved since the early 2000s, but the data I gave you are the most recent data that we have, and we don't have systematic data measuring this problem since then. So, our research program really is aimed at closing this gap in tobacco cessation service delivery to our veterans with PTSD by finding an innovative means of delivering this care in a way that's accessible and tailored to the needs of this specific vulnerable population of veterans with PTSD. Well, let's talk a little bit about some of the barriers that have gotten in the way. What's happening in the system that keeps people with this serious, life-threatening addiction from getting the treatment that they desire. Well, first of all, I think the first biggest problem is that healthcare systems have tried to provide brief episodic tobacco cessation treatments, which are no match for this chronic relapsing disorder of nicotine dependence in so many of our patients, both veterans and non-veterans. That's a main problem. You heard me say it over and over again, is that we can't treat a chronic relapsing condition with a brief episodic treatment. Second of all, there's limited provider time for repeated monitoring of tobacco use status and response to relapse and pursuit of dropouts. This is important because about 80% of people who try to stop smoking, and this is the general population, not just psychiatrically ill people, but the general population, 80% of them are going to relapse within the first month. And if you're not there to pick those pieces up and reapply treatment and encourage repeated quit attempts, those people aren't going to be successful over the long term. So you end up with a situation of people who try to quit on their own in the vicinity of something like 3% are actually going to have been quit a year later. So that's an issue. Provider beliefs that tobacco cessation treatment is ineffective or uninteresting to do. That's key, because in reality, if quit rates are 10 to 20%, that means you're failing as a provider the balance of that time. And that's not very encouraging for us as providers to more often than not lose in helping our patients. So it's easy to kind of give up on this. Also, it's very easy for providers to slip into the trap that, hey, tobacco cessation is not my business. That's somebody else's problem. That's primary care's problem. That's a smoking clinic's problem. I'm a mental health provider, and I do depression and PTSD or schizophrenia, whatever, and that's my focus. It's not my concern. There's other beliefs that get in the way, like stopping smoking will make my patient's psychiatric symptoms worse. This is what they use to cope, so I don't want to do that. Let's not upset them. Patients don't really want to quit, when in fact, as I mentioned earlier, 50 to 70% of patients want to quit. Even mental health patients, about 50% want to quit. So these are the main issues. There's insufficient training, I think, in tobacco cessation treatment. There's more to it than just writing a prescription. And in particular, there's limited time that providers have and training that providers have had to address this problem of tobacco dependence that's complicated by a mental health problem like PTSD or depression or any other psychiatric condition. Well, I listed 3 platforms earlier for how to deliver tobacco cessation treatment: specialty clinics, primary care, quit lines. There's a fourth, actually. That fourth is for mental health providers to do tobacco cessation treatment themselves for patients under their care. That's the other option, and here's why that might be a good idea. First of all, we come prepackaged with advanced training in treating behavioral and substance abuse disorders that are applicable to nicotine dependence. Most of us get that training in our graduate school. It's a short stone's throw to apply that to nicotine dependence, because an addiction is an addiction in many ways. Second of all, we're positioned to tailor our cessation treatment to address this dynamic interaction of tobacco use with psychiatric symptoms. In other words, many of our patients smoke because they feel bad, and they feel bad because they don't smoke. So this interplay of mood and that's driving addiction and withdrawal from addiction, potentiating mood disturbance, is our business as mental health providers to deal with that edge. And then I think key is the frequent and continuous nature of mental health care promotes ongoing monitoring of smoking relapses and then recycling or reapplication of treatment using a chronic disease management model. And that's key. Chronic relapsing disease, we use a chronic relapsing disease approach to address that. And because we see our patients oftentimes weekly or monthly, we have a much better crack at it than I think many primary care providers who might see their patients only a couple of times a year to detect relapses and respond to those relapses. So these are the reasons why mental health providers are an ideal platform potentially to address this problem in our patients. So there's been a kind of a progression over the years in my work with veterans with PTSD from the time I got into the business in 1970 until about the early 2000s when Andy and I got together and decided to take on this course of research. When I first started with Vietnam vets, working with him in psychotherapy in the 70s, the topics of concern that they had when they were in their late 20s, early 30s, raising families, keeping a job, helping them cope with tormenting nightmares and other symptoms of PTSD. And we did this in smoke-filled rooms with ashtrays conveniently dispersed about. And as the groups progressed, over the course of a 60-minute hour, the ceiling would literally become lowered from the smoke ceiling. And I'd go home with nicotine-saturated clothes and thought nothing of it. That was the culture. That's what we did. You could even buy cigarettes at the local VA hospital canteen back in those days for 21 cents. But over time, by the early 2000s, the topics of discussion in our groups, when our men now were in their 50s or early 60s, had shifted dramatically. They were now dealing with challenges of chronic illness, growing physical disability, and loss of functionality. And then finally, around 2002, I decided I had enough when I sat across the room from 8 of my combat veterans in a group that I ran, and finally did some calculations and determined that all but one had one or more chronic diseases: COPD, diabetes, cardiac problems. One had recently died from lung cancer. One was on an oxygen tank, and all had been smokers, and half still did. At that point, Andy and I saddled up and decided we had to do something about this devastating addiction for our veterans who we had grown so fond of over the years. So we decided, let's see if we can do a study. Actually, it was published there in American Journal of Psychiatry, a pilot project, seeing if we could compare the effectiveness of doing a brief integrated care approach for tobacco cessation versus VA's usual standard of care for tobacco use in our veterans with PTSD. So basically think of integrated care as involving combining treatment for tobacco dependence and PTSD into one clinical setting, namely the PTSD clinic, with care for both conditions delivered by a single provider team using a chronic disease management approach, emphasizing extended treatment of nicotine dependence over time. So that's really integrated care. Think of it more simply as one-stop shopping. PTSD, tobacco use, all in one place, rather than referring patients out and making it somebody else's problem to fix. It's our problem to fix, just as we take care of so many other co-occurring problems: domestic violence, homelessness. I don't refer that out for somebody else to take care of. I handle that as the person's primary mental health provider. So why am I referring out nicotine dependence for somebody else to handle? That's the concept. So we compared integrated care against VA's usual standard of care, that is these high-end tobacco cessation clinics, to see what we got. And this is what we got. I was going to be hopeful if we, integrated care, which are the blue bars, did as well as the experts, the pros, because they're pros, and because none of the rest of us in the PTSD clinic had any idea what we were doing, to be honest with you. I went off to the Mayo Clinic, took a 3-day seminar on how to do smoking cessation clinic, having not treated one patient myself for this condition, came back, wrote up a little manual, distributed it, declared myself an expert, and said, let's go do this. So you have a team of PTSD clinicians who had not treated one patient for nicotine dependence up against the pros, the tobacco cessation clinic, that do this all day long. This is the result. Maybe look at the 9-month mark. That might be the better indicator of longer-term abstinence, although not without flaws, which we'll talk about later. But this is point prevalence abstinence that's bio-verified, meaning the patient has not smoked for 7 days before they came in for the study measurement visit, and that was confirmed by carbon monoxide readings that were within the normal range. So you can see that we're somewhere around, looks like 18% or so at the 9-month mark, and we clearly did better than the usual standard of care by a country mile. So we got lucky. Let's do a little effectiveness trial here, which is essentially an open label study, if you will, an open trial without a control group. We felt like we had demonstrated that against a control group we had prevailed. Now let's see if in real life, in a clinic setting, we can actually get clinicians to do this for the long haul. Well, sure enough, here we go. 107 patients treated by our PTSD clinic clinicians, like myself, and these are the quit rates. Pretty much the same story. Pay attention just to the red bars. Those are the quit rates. In 9 months, it's about 18%, if I got that right. The blue bars, I put them up there for illustration, but don't really pay attention to it because it's deceiving. The blue bars reflect what happened to patients who didn't quit in terms of percent of reduction of cigarettes per day smoked. So that looks kind of like good news, but we don't encourage reduced smoking as a goal. First of all, a lot of people who engage in reduced smoking relapse back to full force when stressed. Second of all, reduced smokers tend to smoke the cigarettes they have harder and hotter, and they get a hotter burn and ingest more carcinogens. And then third of all, there's no real good medical evidence that you benefit from reduced smoking. So abstinence is the goal, period. We're not after reduced smoking. these two preliminary pilot studies told us that it's feasible for busy mental health clinicians in a very busy VA clinical setting, treating combat veterans. Again, many of them were recently back from the wars, because we started Iraq and Afghanistan, so we had a lot of business, and we were very, very busy. These busy clinicians were able to incorporate tobacco cessation into their day-to-day business on an ongoing basis without really much complaining or aches and pains, with the results that you just saw. This then leads us to Dr. Saxon to talk about the next step, which is a multi-site clinical trial recently published, and how we got there and what the results are.
Good afternoon, everyone. So that's great. With Miles as champion leading the charge, we could get the mental health clinicians in our own PTSD clinic to do this work, and we got a good result. But to really demonstrate that this technique is effective at getting people to stop smoking, we need to do this in a larger trial, in real-world settings, in places where we weren't there to potentially influence the outcome. And that led to this multi-site study that I'm going to tell you about, which we are very grateful that VA Cooperative Studies program funded. So we want to find out whether integrating smoking cessation treatment into mental health care for PTSD improves prolonged abstinence. So Miles showed you in our pilot study, we were looking at point prevalence abstinence, being abstinent for 7 days. Prolonged abstinence is a much higher benchmark and a much more difficult outcome. And we used a fairly innovative design in that most clinical trials start measuring outcomes from the point of randomization. And we realized with smoking cessation, it takes people a little while to get in step with it, and sometimes they might start to quit, have a little relapse. We can work with them, get them stabilized again. And so actually our measurement time point for our primary outcome starts 6 months after randomization, which is a really unique design. But we wanted to really determine whether these are serious long-term quit rates. So what we're measuring is from month 6 after randomization to month 18 after randomization, not just point prevalence abstinence, prolonged abstinence. And that doesn't mean that there's absolutely no smoking, but it means that if someone smokes 7 days in a row, any time during that 12-month period, they're knocked out. Or if they smoke on any given day in 2 consecutive weeks, they're knocked out and they don't exhibit prolonged abstinence. And we compared the integrated care that we developed to referral, as we did in our pilot study, referral to the smoking cessation clinic. Every VA is required to have a smoking cessation clinic, and they all existed at the VAs where we did this study. Besides our primary outcome, we wanted to look at, well, if this works, what are the factors that might contribute to its effectiveness? And a very burning question at that time, which I think our study and other studies have really answered, as you'll hear, people were really concerned that having patients with mental disorders try and quit smoking would destabilize their mental disorders, and that was a good excuse that we all used not to address the nicotine dependence. I think we now know it's the opposite, and we'll show you some of the data. So this was a randomized controlled clinical trial comparing integrated care to smoking cessation clinic referral. We had 943 patients randomized at 10 different VAs around the country. So we couldn't be everywhere at once influencing the outcome. So we have a manual that I wish I wasn't a federal employee, because I probably could have made some money out of copywriting this, but it's freely available to anyone who wants it. And it involves 5 sessions. They're all very well laid out. I'm not going to take the time to walk you through it today, but if there's questions about how the sequence goes, we can let you know. And it's, we believe, a very simple manual to use. I think we demonstrated that in this study, because the way we trained providers to do this is we had a central kickoff meeting where we had a couple of providers from each one of our sites come and work with us. Basically, they got 1 day of training in how to do this, and they went back to their sites and trained all the other providers in their clinic on how to do the integrated care. And then we had a fidelity measure where Miles had gone to the Mayo Clinic to get his training. They're kind of the top tobacco cessation people in the country. So we asked them, we want you to listen to audio tapes of our clinicians doing the treatment, the 5 sessions, and we want you to rate those audio tapes and make sure that they're following the manual. So we had that fidelity check, and it turned out with the train-the-trainer model, and then people who were trained over one day going back and training other people over about one day, something like 80+% of the clinicians who did this treatment the very first time were rated as successful by the Mayo Clinic. So there are 5 sessions. Medications for tobacco cessation are strongly encouraged, and of course most patients want to use them, but they weren't required and they weren't controlled in the study at all. The only control is whether they got integrated care versus referral. And there's also a package of self-help materials that the patients get to do some homework at home. And after the 5 sessions, there are 3 post-quit sessions. So people go through 5 sessions, their quit date is after the 5th session, and then we see them at least 3 more times in follow-up to help support a successful quit or to recycle if there's a relapse and get them back into an abstinent state so they can continue to be smoke-free. So just as in our pilot study, the primary mental health provider who is doing the PTSD care for these patients is the same person doing their smoking cessation treatment, and oftentimes it is an individual-based treatment right now, and usually the smoking cessation sessions take about 20 to 30 minutes, sometimes even less, and the rest of the session could be devoted to PTSD or even how their smoking issues intersect with their PTSD symptoms. People in the PTSD team, either the psychiatrist or nurse practitioner, would prescribe the medications for those patients, so they had pretty easy access to medications if they wanted them, and then they were able to follow them very, very carefully. So we didn't control what was done. This is a real-world effectiveness study. We didn't control what was done in the smoking cessation clinic. We did interview the lead clinicians in those smoking cessation clinics and ask what they were doing, and we were convinced that they were all providing evidence-based care. So who were the people that we were treating? I'm told I can use this as a pointer. Is that working? If I can control my tremor, yes. The majority were Vietnam-era veterans, so in their mid-50s primarily, mostly male, as you would expect in a VA sample. We actually had a oversampling, which was good, of African Americans, and the majority were no longer married. About 3/4 of them were no longer working. 3/4 were also from Vietnam era, but we also had 13 or 14% from the current wars enrolled in the study. This is just like most people who smoke. They started smoking in their late teenage years. They've all smoked most of their adult lives. In this group, they averaged a little over a pack a day of smoking, but between 25 and 33% of them were heavy smokers, consuming more than 25 cigarettes in the last 30 days. And many of them had made prior quit attempts, but didn't sustain their ability to quit with long-term abstinence. Many of them had been to the smoking cessation clinic and didn't have ultimate success there. The Fagerstrom test for nicotine dependence is the most widely used measure to get an estimate of the degree of physiologic dependence on nicotine that people have. It's a 6-item self-report measure, and the 2 most key items are how many cigarettes do you smoke in a day and how soon after you wake up do you smoke your first cigarette. And people with severe physiologic addiction wake up in withdrawal, and the first thing they want is that cigarette. So what you can see is, actually I think it's going to be easier if I just point to it. So you can see that we had over 1/3 of our people were considered to be highly dependent on nicotine by that measure. Besides PTSD, these people had a lot of co-occurring mental disorders. Almost half of them had current major depression, a bunch of other disorders. We did exclude people with current substance dependence, but many of them had past serious substance dependence. About 3/4 had alcohol dependence in the past, and you can see there's some other drug use disorders that they also had. The CAPS is the clinician-administered PTSD scale, which is a structured interview administered by an experienced clinician. That's the gold standard for diagnosis of PTSD, and having a score in the mid-70s is a substantial case of PTSD. The PCL PTSD Checklist is a screening measure for PTSD, and it's also becoming used as an outcome measure, as you'll see. And a score of 50, it goes through all the items that make up the DSM-4 diagnosis for PTSD and rates their severity, and a score of 50 or above is considered to be a positive screening for PTSD, and you can see ours were at about 60. And almost all of them were on a lot of different psychiatric medications. So it's a pretty sick population. So what did we find? This is the major story here. We're looking at the prolonged abstinence. Again, that's basically being a non-smoker from month 6 to month 18 for an entire year. In the upper part of the slide, we're seeing our self-reported rates of prolonged abstinence. The lower part, the bio-verified. So by self-report, about 15% plus of those in integrated care said they had not been a smoker for a year, compared to 7% who were referred to smoking cessation clinic. And you can see that's about 2.5 times the odds of quitting. Now, there is a big discrepancy between the bio-verified and the self-report. So the way we were bio-verifying, and the bio-verified, we got about close to 9% quitting in integrated care compared to 4.5% who referred. So we're seeing the same difference. That doesn't change based on how we measure it. There are two primary ways you can biologically measure exposure to tobacco smoke. One is, as Miles already mentioned, getting a breath carbon monoxide measure, and smokers tend to have an elevated breath carbon monoxide measure. The other way is to measure cotinine, the nicotine metabolite, in some body fluid. But that is difficult to do if people are on nicotine replacement therapy, because you don't know whether the nicotine is coming from their medication or from their smoking. So we did have some issues. We were pretty sure the CO monitor at one of our sites was malfunctioning, because even the staff who were non-smokers were getting a high reading, and we did replace that unit, but we couldn't change the data. And then there are lots of other reasons why people might have high carbon monoxide levels, from auto exhaust, from the heating equipment in their home, from secondhand smoke, yes, from smoking marijuana. So it's not a perfect measure, and we believe the real quit rates lie somewhere in between there, but very few, if any, other smoking cessation studies, particularly including people with mental health disorders, have looked at such a rigorous outcome. So we're fairly happy with the almost 9%. And if you saw that slide at the beginning relating to Alzheimer's disease, even reducing smoking rates by 10% can literally prevent thousands of cases of Alzheimer's disease. We also did the point prevalence, so that's just have you quit for the past 7 days, both by self-report and bio-verified. And this is a good comparison to other studies, because that's the typical outcome measure that's usually used, because it's only over 7 days that you really can bio-verify abstinence. And, again, we're seeing a difference between the two, but the two conditions, even in this measurement, the integrated care does better than the referral care. So what might have caused this very positive result we got, encouraging result? So one of the things we looked at was the number of treatment sessions that people had, and not a big surprise. The people in integrated care got, on average, more than 8 sessions, and the people who referred to the smoking cessation clinic got on average 2.5 sessions. Actually, I was really, you heard half the veterans in our place who got referred to smoking cessation went once and never went back. So I was impressed that they actually did get some treatment and some care. That wasn't just a proxy sort of control condition. And you can see the numbers of sessions that people got. I mean, most people went at least once, but the people in integrated care did get definitely more behavioral intervention. Here's the medication that they got, and Again, this isn't controlled. It's between them and their prescriber deciding what medication. I put the whole thing up here so you could see the range, but really the important point is really in the first row. So any cessation medication, numerically the integrated care was a little more likely to get any medication, but the important thing is the number of days of medication. They got 165 versus 131 days, which was statistically significant. And so it turns out if we look at how much of the treatment effect we can explain, about 30% of the treatment effect was explained by the number of sessions people got. And about 9% of the treatment effect was explained by the number of days of medication that they took. So we still have, so we do know that both of these things are a factor in effective quitting. We do know that integrated care delivers them better, but we still have 60% of the treatment effect unexplained that we speculate has something to do with the relationship with the provider, that this is someone they know and trust who's taking care of other aspects of their lives, and that may have a big impact on their ability to quit. Well, did we have any adverse impacts on their psychiatric condition? So whether people were in integrated care or referred to the smoking cessation clinic, these are the clinician-administered PTSD scale scores, which are really the best way to measure PTSD symptomatology. Both groups had about a 10% reduction over 18 months. So what is it? And that's a clinically meaningful difference. So what does that show? That shows that the PTSD care that we're providing really works for these veterans and helps them. And if you, no matter which condition you're in, you're going to get better. You're not going to be adversely affected by having more smoking cessation in the treatment setting that you're in and having integrated care. So this looks at the CAP scores by the 12-month prolonged abstinence. And again, those who quit smoking didn't have any worse PTSD outcomes than those who didn't quit smoking. Looking at some of the same issues, we're looking at, this is using the PHQ-9. I'm sure people are familiar with that. It's a self-report measure of depression. This is the PTSD checklist that I mentioned earlier. And we're tracking integrated care versus smoking cessation clinic. It seems like for some reason we don't totally understand yet. Depression increased a little bit. Started, at a level of moderate depression, got a little worse for everyone, and then got better towards the end of the study. As with the CAPS, the PTSD symptoms are going down, but no difference between conditions. And this is looking at the same measures between those who had succeeded with prolonged abstinence and those who didn't. And again, you can see quitting smoking doesn't cause any harm or worsen anyone's mental health disorder. So we found that integrated care worked about twice as well as referral to a smoking cessation clinic. We know it worked in part because it could deliver more behavioral sessions and get people to take medications on a more regular basis. We didn't see any adverse impact on psychiatric conditions whatsoever from either the integrated care package or from having people actually quit smoking. And this was a very practical trial done in real-world settings. People were able to learn the therapy very readily and apply it with fidelity. There have not been very many large studies of randomized controlled trials of smokers with mental illness, and so in that way this is kind of a landmark bit of work, if we do say so ourselves. And it demonstrates the value of looking at tobacco dependence as a chronic disease that's going to require ongoing management. There's the potential to really, if we say that we know this works for PTSD, we suspect it would work for other mental disorders. If we could apply it to the millions of people who are under psychiatric care in this country, we could probably create hundreds of thousands of former smokers, and so we're hoping that might happen. Although usually in this kind of situation, someone develops an evidence-based treatment. Like how many of you are going to contact me and say, send me the manual, I'm going to start doing this work tomorrow? Probably not very many. You're too busy, you're already overcommitted. But most of the times these good treatments just sit on the shelf and never get used. we're very lucky that the VA decided to recognize the value of this and help try and move it into clinical practice. So the next part of the talk, Miles is going to tell you a little bit about what we've been doing the last year to try and actually implement this broadly across the VA.
Well, we'll make this really quick because I think we want to have time for questions, and I understand you end at 1 o'clock. Is that correct? Yeah, so we'll make this very fast. So just one more comment about the results of the study. We did have a health economist as part of this who just finished their analysis. Long and short of it is there was no difference between integrated care versus standard care in costs. Costs are determined by cost of the intervention, plus costs of other associated health care delivery, costs of patient transportation to and from the facility for treatment, et cetera. Health economists have very sophisticated models, but the short version is no difference between the two conditions in cost, but twice the result from integrated care. Okay, twice the result, no difference in cost. So maybe in less than 5 minutes, I'll just show you a little bit about what we're doing. I just read an account that after the discovery of scurvy was scientifically determined by a scientist, who's a fleet captain in Britain. It took the British Navy 200 years to actually implement that preventative strategy, dietary supplements, throughout the British Navy. So the issue of innovations in healthcare, having trouble getting it to take traction in the field is not unique to healthcare. But I think we're well aware that publishing findings in a scientific journal like this may very well be just interesting news until the next issue comes out and not lead at all to any change in practice. So I am convinced, as others, of course, that you really need to have a distinct and separate project that's aimed at rolling out innovations as opposed to expecting it just to happen all by itself. So the VA has implemented something called a learning collaborative. Now, in the interest of time, I'm just going to truncate this just very quickly. But basically, without paying too much attention to the slides, it's a way of teaching clinical sites how to do the innovation and training their skill set, and then monitoring them to make sure they do it by providing them with consultation, monthly conference calls, face-to-face meetings as indicated, as well as performance monitoring and feedback. That's essentially what we did in this thing called a learning collaborative. Now I'm going to skip forward a little bit, but the steps of this learning collaborative are as you see there. This is piloted at 6 VA medical centers, PTSD clinics. We started this about a year ago, and it's coming to its conclusion. The Learning Collaborative involved these steps that you see here, which is first of all to get an expert panel together to formulate what the objectives are, what the goals are for what we're trying to change. Then you gather up the participants, in this case 6 participating sites, and engage them in conference calls, readings, to build momentum and buy-in before they meet in a face-to-face session to train them in the innovation, which is what we did. Then that's typically what happens at most places, which you go to a conference, you all have a great time, and then you go back to your home site and nobody does anything. And everything would have just basically stopped there had we not taken the next steps, which is ongoing monthly conference calls, 2 additional in-person meetings to solve problems, deal with barriers, both institutional and at the provider level, sustaining momentum by having monthly newsletters that go out, posting best practices on a SharePoint, which was really a winner because this became a case where the teachers became the learners, and the people who adopted this model suddenly took over and were doing very innovative things that we had never thought of. And our job was basically just to step back and stay out of their way and let them do their work. So there was a lot of collaborative sharing of how you do integrated care. And many sites went far beyond what they were asked to do. They were asked, do tobacco cessation with PTSD patients in your PTSD clinic, and that's it. And at some sites, they went way beyond that. They started doing this in their general mental health teams, in their residential and inpatient psychiatry teams. Our hospital director at one site, Cleveland, said, I want you to roll this out VISN-wide and go train everybody in your VISN. In the VA, a VISN is a region. In our region, it's a 4-state region. It differs across the nation. But some sites just roll this out throughout their whole multi-state region, far beyond PTSD clinic because of their own enthusiasm. Monitoring outcomes is key to appeal to people's competitive juices, frankly, and show them who's doing what, as well as make individuals accountable for, in fact, recruiting patients and providing the intervention. And then we kind of had an additional component, which is how to promote sustainability after we go away, meaning the Learning Collaborative, which ended at the end of a year. How are they going to sustain that effort going forward? Let me just show you a couple outcomes. This is the outcome of this Learning Collaborative. After about 9 months, we had 24 providers or clinicians in the PTSD clinics that delivered integrated care to 3 or more patients. That ended up being 156 patients, got 1 or more sessions of integrated care. The rest are in the pipeline. 89 patients completed the 5 core counseling sessions. And 49 patients had reported making an abstinence attempt and getting follow-up sessions. So those are some of the concrete outcomes while this thing was at the 9-month stage, and we think things are better as we're nearing the 12-month mark now. I'm going to fast forward to a couple of other things and then stop so we have some questions. The National Center for PTSD is a VA resource, really, to do scientific research and education in the VA and beyond. They have picked this thing up, namely our treatment manual Andy showed you, into an iPhone application. I guess that's what people do these days. They have iPhones and they make applications so that patients who are trying to quit smoking can call up on their iPhone this menu of options, click on it, and get help in coping with smoking urges or recovering from a relapse if they relapse. So this is kind of the menu of options that they have available to them, all in an iPhone application that is now being beta tested. We also have a web-based training series. Basically, it's this talk plus practical hands-on training of how to implement the clinical method. That's now sitting on the National Center for PTSD website. I believe people outside of the VA can even go to that and basically get a how-to-do-it course on how to do tobacco cessation that improves portability. Last but not least, we realize that, well, I don't see the slide on there, but reading scientific journals isn't something everybody does. So there are a number of kind of publications that providers who are busy clinicians read that end up in your mailbox as throwaway journals. So we've basically published our findings in those types of avenues that are readily read by clinicians, and you don't have to wade through a lot of statistics. So the Agency for Healthcare Policy and Research adopted this as an innovation that they put on a website that's easily accessible, and a dozen other kind of magazines like U.S. Medicine and others that really boil this down to its nuts and bolts for providers with a hands-on clinical application to get their hands on. So I'd say that's our talk. We have a little bit of time for questions if we can entertain those, and also get our experts, our IT experts, to work the web thing. So, yes, sir.
When you're dealing with PTSD, when and how do you introduce smoking cessation as a treatment?
Well, I mean, usually the way it works, at least in the VA, is we do, of course, a diagnostic workup and intake in which you essentially make your diagnosis that you're trying to tackle into a treatment plan. And then we simply negotiate with the patient, look, you've got these 3 or 4 problems. You know, you're homeless, you have PTSD, you have a substance use problem, you have tobacco dependence problem, whatever that might be. You have marital dysfunction, you kind of list those. And then we typically make a recommendation to them about what we recommend they tackle first. The patient may be suicidal, of course, and then we're going to recommend those urgent issues be tackled. And then we simply negotiate with them, when should we do what, collaboratively? And it's a two-way process. Sometimes the patients say, I can't deal with smoking now, my plate's full, you know, I'm so depressed, we'll deal with that later, and you say, fine, you know, and you back off. And as long as you as a provider remember that 3 months later, after they're stable and their presenting problem has kind of been handled, you say, remember tobacco dependence? We talked about that when we first met. Are we about ready to get to that? And so you do have to be assertive about reminding them of that treatment plan. Other patients who come in, they want to do tobacco dependence first because it gives them something concrete to deal with. It's more concrete than dealing with trauma and so forth, which is harder. And other patients will do it simultaneously. Okay, we have a 60-minute hour. let's spend 20 minutes of it talking about tobacco dependence, because that's what's maybe going to kill you, and the other 40 minutes talking about your marital problems or your combat-related problems. You basically integrate it into one session, and they tackle both simultaneously. So it's different strokes for different folks, depending upon what they want. Other questions? Yes, ma'am.
I'm curious, was there a portion of this that focused on anxiety sensitivity, since we have elevated certainly folks with PTSD and also folks with
Yes. The treatment manual that Andy pointed out actually isn't just how to keep people from stopping smoking, what drug to prescribe. There's an appendix in there which deals with that dynamic interaction between PTSD symptoms and smoking. And there's really guidelines for providers as to what to do with patients who say they smoke because they're angry or anxious or depressed or have anxiety sensitivity. So it's really pointers to clinicians about do these things here. These are the menus of interventions available to deal with mood-related problems that may be drivers to their tobacco use. And certainly anxiety and stress and anxiety sensitivity is part of that. So that appendix rests there, although the clinicians typically know what to do anyway. We have it there particularly for newer clinicians. Yes, Richard.
I was struck by some interesting parallels. We use the word integrated care more often around here in the region in the dissemination of collaborative care of depression, anxiety, and primary care. And it goes back, obviously, to a number of studies we've all done here, but the key study being the IMPACT project that Jürgen and others did.
Mm-hmm.
And one of the key features that clearly allowed them to achieve the same sort of outcome, the doubling of response rates to depression and very unusual care, were some of these very same features where you've got somebody in the room or on the phone actually tracking what's going on, actually maybe measuring what's going on, and then intervening because you're realizing, they're falling off the tracks. And I was just really struck how important those attributes are as opposed to, gee, come back and see me 3 months or 6 weeks or whatever it may be.
It's do today's work today. One-stop shopping, kind of simplicity, improves access. Things don't get forgotten about so easily, and they don't get turfed out to other people who may not be thinking that's really their job either. So it really, I think, is maybe an approach that isn't specific to that or us. It may be an approach that's more universal to behavior change in a variety of domains. Yes, sir.
What's happened to the smoking cessation clinics within the VA, given these findings?
Whether the VA, whether these findings will in any way change the smoking cessation clinics, I don't know. I doubt it because they serve the whole population of patients who smoke in the VA as a resource. So just because the PTSD patients would be better treated in PTSD clinic doesn't mean that they don't have a mission. They still do have a mission, which is all the other smokers. So they're kind of in some ways glad to see this because they'll say, thank God, you guys handle the PTSD patients. We need our resources to handle all the others. But having said that, those clinics are tending to diminish somewhat, and care is being shifted over to primary care providers, which has advantages because it's less referral-based. It's more integrated within primary care. But it also has the problem of primary care providers see their patients quite infrequently, and maybe they have a 15-minute appointment or half hour, and they're dealing with a long list of problems, and whatever they do for tobacco cessation may be very, very brief, like a medicine and some encouragement, but it does not necessarily have the intensity needed to treat intractable chronic smokers, particularly those with mental illness. And the studies about primary care providers, and this is not VA, is that they're great at screening and detecting tobacco use. They're great at advising patients to quit. But when it comes time to treating patients and following them, those numbers are under 20%. In terms of actually writing a prescription, giving them the necessary counseling, and following up, under 20%. And those data are even recent. So I have some concerns about that being the only venue. Maybe it would work better for a non-mentally ill patient. Yeah.
Just another follow-up. Another common theme to a lot of these interventions is that there are a significant number of people that don't get the benefit we want. So I'm curious as to what your thoughts are about the 85 to 90% that aren't getting that sustained cessation.
In our own study?
Well, the answer, Mark, is we obviously need to develop much better treatments. I don't know. The behavioral intervention here is pretty good. It may not be the be-all and end-all. The Mayo Clinic does inpatient treatment for tobacco cessation. I mean, when we have psychiatric patients with other disorders who were failing as outpatients, we admit them to the hospital. And maybe we need to be putting more of these people in a controlled environment to help their quit. We clearly need better pharmacotherapies too, and better ways to administer the pharmacotherapy. So a lot more work has to be done, but we do think getting 10 or 20% of people to quit is going to have a big impact, and so we shouldn't get too nihilistic about it, but we have to do better and figure out what's going to work for different people and probably intensify treatment.
One common thought, though, is that extending the treatment, that for as much as we would like to have this be considered a chronic treatment, the trial by definition has to have a beginning and an end.
Yes.
And yet, it may be that these people needed something that was longer. And
Yes.
is that anything that you're thinking about?
Yeah, I think that you just have to keep banging. And you're right. The trial ended and it was cut off. But who knows what happened after that point? And actually, you may have seen on the point prevalence abstinence rates. Actually, the highest point prevalence abstinence rate was at month 18, 18%. So there was some upward tick that may have reflected just what you're suggesting, which is the providers kept banging away and helping people make multiple quit attempts. But then the study ended, and that's the end of the data. That may be the key. That becomes a challenge to study it.
But in your real-world efforts, are there limits, or could people really stay at this as long
You just keep you keep banging. You keep banging as long as the patient's enrolled with you and you have an opportunity to see them. I mean, if you're seeing them monthly for med checks, sometimes for years, there's no reason to say, "And how you doing with your smoking?" Oh, I relapsed, doc. Well, no problem. Let me intervene. I think the barrier is the providers letting it drop off their radar.
Yeah, I have patients that I've treated for 10 or 15 years, and I think they're never going to quit smoking, but I still keep working on it, and then lo and behold, they do quit. And so keeping at it really does, we can't show that from our data, but from clinical experience, that really does work.
And their circumstances change. I had a patient like this in this group I told you about. The one guy that didn't have a chronic disease, he was the guy that was always kind of leaning over in groups so that we could all see his camels that would fall out and he would kind of taunt me with it. Well, as time went on, he got married, and his wife said, "You need to stop smoking," and he's ready to quit smoking, and he in fact did quit smoking quite adroitly. So their circumstances change, and that was 10 years later.
What's your problem?
That was 10 years later, so you just keep at it and look at opportunities. And notice how adroitly I hand the hard questions off to Andy. Yeah? Any other questions, or are we pretty much out of time here?
The manual you talked about, is it on that link that you guys showed? The VA?
Do you know? I don't know.
It's on a link somewhere, but you just send us
really lost.
it'd be easier if you just send us an email. We'll send it to you.
Okay.
That'd be easier. Yeah.
Yeah.
Thank you very much.
Thank you.